And good day, and welcome to this next session, which are proffered papers with respect to a very interesting topic and session. We'll be looking at the impacts of the COVID-19 epidemic, and we've assembled a number of presenters today who will be providing some important context in light of our great conference. We will first start off with Ms. Kathleen Powell, then we'll have Navya Tripathi, and then Sabrina Brown. So my name is Dr. Oscar Allen. I'm from the National Association of County and City Health Officials and on the part of the planning committee for the LEPH conference. So it is a pleasure to have you all attend, and I will turn it over to Kathleen.
Great, thank you. So I'm just going to share my slides. And there we go. All right, thank you so much for the introduction. Getting ahead of myself. So hi, everyone. My name is Kathleen Powell. I'm a postdoctoral research fellow at Drexel University. And today I'm going to be sharing some research that I completed this summer with my colleagues, Jordan Hyatt and Nate Link. And we were looking at the COVID-19 pandemic and its influence on community corrections, so probation and parole, and trying to understand kind of what changes happened in this in community corrections themselves, and trying to think to the future as to what these might mean for long-term reform in this particular aspect of the justice system. And we focused on community corrections because it presents an interesting context in the pandemic, because community officers of probation and parole kind of straddle this dual role where they are responsible for correctional oversight and providing support, but also are responsible for law enforcement activities, holding individuals accountable to their terms of supervision and enforcing those rules. And so our study was really animated by two research questions. The first one sought to just document the changes that were happening on the ground in response to this novel and what I sure hope will be once in a lifetime pandemic, and trying to understand how it changed community corrections, kind of the old normal. The second facet of our research was to understand the implications of these policies and get a sense of what might persist into the future, and trying to ascertain whether the pandemic would really kind of generate this long-term and substantial reform in this particular space in the criminal justice system. And so our study featured the perspectives of chiefs of adult probation and parole, and we focused exclusively on Pennsylvania. In Pennsylvania, most community supervision is administered at the local level. So we were focused on these county level agency leaders that have a lot of discretion and autonomy to shape policy on the ground. I'll note that there is a little bit of supervision that happens at the state level, but for all intents and purposes, we kind of got a sense of what was happening for the vast majority of people who are on community correction supervision in Pennsylvania, which is much higher than the national average. Pennsylvania has quite a high use of supervision relative to other jurisdictions and states. So our study design was mixed methods, and we collected our data from July to September of 2020. So about 4 months into the pandemic, if we're thinking of March 2020 as that initial start point. So our data kind of speak to that initial impact to the system, that initial shock and response, that period of adaptation. And in July, some offices were starting to reopen and there was some kind of return to normal. So we were able to get a sense of a lot of things that were unfolding in a short period of time. Our first piece of data was an anonymous survey that we fielded online. We got 46 responses, which was a 71% response rate, which we were very proud of and very happy with. And 88 questions, just again, documenting these changes that were happening, obtaining a sense of their perceived impact and what agency leaders' concerns were heading into the future. From there, we also collected confidential, semi-structured interviews with a subset of survey respondents, again, documenting these changes, but with the lens towards understanding the motivations for the changes, the process that underlies the changes, and their perceived impact on operations. And so we heard kind of these contextual dynamics that really impacted that immediate shock period of the onset of the pandemic. And so agencies were faced with these immediate, really salient pressures where they were forced to continue their essential work. They were designated as essential functions, even as shutdown orders were handed down and people were asked and strongly advised to stay home. Understanding them as essential work, they also, agency leaders had to figure out how to do that work in a space that was kind of upended, right? Where normal office work and supervision contacts in the office or in other people's homes couldn't really happen. There was this new novel health risk that accompanied it. So trying to figure out how to make things work in this new landscape. And finally, receiving pressure to reduce their local jail population. So court leaders in counties were asking probation chiefs to reduce the number of people who were incarcerated with probation pending matters in their local facilities, of course, with the idea of reducing populations in congregate settings and those transmission risks. So survey data revealed this really substantial immediate impact of the onset of the pandemic, where respondents rated the level of disruption at 74 out of 100, with 100 being the maximal, so quite towards the really disruptive end of the distribution. They also indicated that there wasn't a lot of coordination between agencies, only a slight degree, if any, which means that our leaders were really tasked with finding solutions on their own on an individual level basis. And finally, because a lot of people were staying home and the police weren't apprehending as much crime, they experienced a lot of fewer cases, but also an increased backlog of cases. And together, this kind of made this moment of like pause and this real jolt to the system and operations. And in that moment, we heard from our respondents that it was a good chance to take a deep breath, think about what they were doing as they were forced to change, and evaluate whether old practices should continue into the future. So one agency leader told us, I think it's given us a really good opportunity to look at how we're doing supervision and consider if we really needed to lock that many people up. Things that we used to be doing, is that really what we should be continued to doing? And it is with that kind of mindset that we discovered there was a significant amount of change in community corrections as had been happening. The first dimension of change was in the supervision contexts themselves and how officers were interacting with the people they were responsible for supervising. So prior to the pandemic, our survey respondents indicated that the vast majority were interacting with the people they supervise using kind of standard in-person meetings, phone calls, text messages to facilitate these contacts. Stories quite different, of course, during the pandemic. And we saw that there was a massive drop off in the use of standard in-person meetings, so in offices or in homes, a rise in the use of phone calls and text messages, and most interestingly, a rise in the use of kind of socially distant modified in-person meetings and teleconferencing. So as you know, I know my life has really transitioned to being on Zoom, so did community supervision. And when we asked our interviewees about what this change looked like in their agency, they described this process of triaging, where they reserved kind of this in-person socially distant interaction for cases that they deemed to be of the highest risk, whether that was the result of a risk assessment tool or internal priorities with respect to drug courts and how people with known like substance abuse or mental health problems are handled. Those people were prioritized for these in-person face-to-face contacts. On the reverse side, anyone who wasn't deemed high risk or high priority was engaging with their officer using these remote methods. So phone calls, text messages, and remote meetings. And it was really kind of reflecting the emergency of the situation. They described it as this triaging process in which really the priority was towards those who needed the most support and that direct interaction. The second major area of change was in case management and the discretion that officers have to respond to rule infractions on supervision. And so we heard in the survey that 96% of respondents continued to respond to direct violations or new crime offenses that happened during the pandemic. Slightly fewer, about 73% of survey respondents said they continued to process technical violations, so rule infractions, positive drug tests, or so on, a little bit less prioritized at this moment. And what we heard in the interviews is that when agencies were changing these policies, really public safety was at the forefront of their mind. They didn't really want to issue violations and warrants for arrest and for jail time unless the action that was at hand really presented a risk to self or others. We heard it was, quote, not a good time to incarcerate people. And so understanding the unique risks of going to prison or jail during a pandemic really had chiefs rethinking their use of this punitive lever for violations in a way that really scaled back its usage. We also saw reductions in the amount of required drug testing in frequency and in use at all. 90% of survey respondents changed their agency's drug testing. And those that continue to do so, again, kind of told us the story of triage, where it was really prioritized for these high-risk cases. So people, again, with known substance use problems and people who are involved with drug court or who rank out as high risk based on an assessment tool. And I'll note that officers got really creative with making this happen, whether it was like dropping off test kits or setting up portable bathrooms outdoors or what have you. They found ways to make this happen for those who it was a priority. Some stopped drug testing at all. And so these were pretty substantial changes that we were finding. And we were interested to know kind of that second piece of the story is, well, what does this mean for the future? And it turns out it means a lot. Over half of survey respondents said that they don't believe that pre-pandemic operations are ever going to fully return, meaning that some things will stick into the future. And this has kind of been a learning moment for agencies. And two main pieces that they think are going to stick, according to our data. Over half see a future role for remote contacts. And this is over half of agencies who implemented more teleconferencing see a role for this in the future. And it's kind of in recognition of the efficiency benefits to operations, the reduced travel and paperwork burdens for officers, but also recognize benefits for the people under supervision. One of our chiefs said that his officers were receiving a lot of gratitude from people on their cases who really appreciated being able to just call into their hearings. It was less stigmatizing, less disruptive to their work schedules, and things that were really fostering their integration in the community. We also heard that chiefs were really interested in continuing to prioritize public safety in how they handled violations and warrants, and really restricting the use of this punitive measure and punitive response. And for a lot of chiefs, the litmus test was public safety, and recognizing that there was not an appreciative rise in crime as they were issuing fewer warrants, were, as one chief said, was begging the question of why they hammer people with so much jail time. And so not only do these results have implications for supervision itself, but also cross over to health and well-being, especially if you conceive of the criminal justice system as a social determinant of health or a salient source of social stress. Say that 5 times fast. So we found that this kind of reduction in the burdens of supervision and reporting requirements paired with fewer punitive levers can really reduce the associated health risks. So for the officers themselves, less occupational stress, more work satisfaction by focusing their efforts towards the cases that are of the highest risk and need the most support. So finding that they're able to prioritize things that they weren't able to earlier because of the hecticness with which pre-pandemic operations were. And finally, for people on supervision, less stress and stigma associated with having to make these really disruptive trips to the office for context. And also this restricted pathway from violations to jail time is reducing the health risk associated with going and serving time in a carceral facility, specifically during a pandemic, but also for mental health, for physical health, and all of the other risks that research are showing are inherent in incarceration. And so thank you so much for your time and attention. And if you have any questions, I'm happy to answer them in the Q&A. So thank you so much.
Thank you so much, Dr. Powell. It is very appreciated, your presentation. Next is Navya Tripathi. Navya.
Hello. Good afternoon. I am Navya Tripathi. I am a junior at Buchholz High School, and I will be presenting with my co-presenter and mentor, Dr. Nancy Hart. As we've all seen in the news, drug overdose deaths have spiked during the COVID-19 pandemic in the United States, as can also be shown in the clippings here. And that leads me to my research topic of the co-location through spatial analysis of COVID-19 and the drug overdose deaths. Our previous knowledge about substance use disorders during the pandemic has led us to find that 37 out of 38 US jurisdictions reported increased synthetic opioid overdose deaths, and 10 Western states reported a 98% increase in substance use disorders. Possible explanation for this could be that people with substance use disorders are waiting longer to obtain their treatment due to limited access during the pandemic, and people who are already in recovery are reporting increased feelings of loneliness, sadness, and anxiety as well. The 12-step recovery that is typical for addiction recovery is also difficult to access at this time due to lockdowns and social distancing. The importance of the drug overdose issue is something we've all been seeing in the news recently, but just to highlight some notable figures, drug overdose deaths in the last 2 decades have increased over 300%. And according to the CDC, over 81,000 drug overdose deaths occurred in the United States in the 12-month period ending in May 2020. This period included months where the United States was affected by the COVID-19 pandemic. This number was also the highest number of overdose deaths ever recorded in a 12-month period. This research aims to identify the hotspots of drug overdose deaths and COVID-19 deaths, as well as determine if there is a significant increase in drug overdose deaths during the COVID-19 pandemic in the United States, and also see if there's any spatial correlation between drug mortalities and COVID-19 mortalities. This research is an extension of my previous research, which was a spatiotemporal analysis of the drug overdose epidemic in the United States on a county scale from 2010 to 2017. From that study, I learned that California, Florida, Pennsylvania, Ohio, New York, and Texas are the top 6 states for drug overdose deaths from 2010 to 2017. This is important to keep in mind since this current study is on a state level, and we will be looking at drug overdose hotspots in more recent years as well. I also found that white males between the age groups of 25 and 54 years are the most likely to become a victim of drug overdose deaths. This graph illustrates the top states with the highest drug overdose deaths from 2010 to 2017. And we can also see that California is significantly higher than any other state. This map of the crude death rate in the United States in 2017 of drug overdose deaths also shows us the spread of the drug mortalities in the United States to give us a visual to keep in mind going forward. And it also reinforces those hotspots which we had discussed previously. These 4 maps also reinforce those hotspots once again, but also show us that white males were the most significantly affected demographic segment in comparison with the other 3 significant demographic segments, which were white females, African-American females, and African-American males. More easily illustrated in this graph, we can see that white males were more significantly affected than any other demographic segment by drug overdose deaths in the United States. For this research, I used data from Esri, US Census, and CDC Wonder in the Esri and Microsoft softwares. Most of my data is concentrated from March to July of 2020 due to various data availability. COVID-19 began in March 2020 in the United States, and the drug overdose mortality data was only available up until July of 2020. And so that's where those are the months that my study is mostly focused on. I have distributed the results between drug overdose mortalities, COVID mortalities, and then at the end, we will look at the co-location of the 2 of them together. Beginning with the statewide drug overdose mortality rate, from March to July of 2020, we can see how in each state, the spread of the rate for each month is quite consistent. And we can see the rate with the colored bar graph, the colors in the bar graphs. And we can see how each bar graph is quite evenly split between each color, which is to say each month. Of the top 10 locales, it's important to keep in mind District of Columbia, Maryland, and Pennsylvania going forward. Now, if we look at the same mortality rate for COVID-19, we can see how inconsistent the COVID mortality rate is for each state, and how each state shows an increased mortality rate at different times. For example, New Jersey shows a relatively high mortality rate in April, whereas states such as Arizona and Texas show a higher mortality rate in July towards the end of the time period. And again, in the top 10 locales, we can see District of Columbia, Maryland, and Pennsylvania to be consistent from the drug overdose mortality rate. These maps illustrate the drug overdose mortality percent change from a month in 2019 to the same month in 2020. While some states did have a negative percent change, which is to say a decrease in drug mortality rate from 2019 to 2020, majority of states had an increase in drug mortality rate, as can be seen from the rate. Many of the states had it around 50% as well, as we can see from the scale. The darker the color, the closer it is to 50%. In every map, we can see the Dakotas and the Louisiana, Alabama, Mississippi area, as well as Maine, to be increasing in drug mortality rate. Oops, sorry. The same data showed in a graph for each month from January to July of 2020. We can more easily see how states initially had a negative percent change in COVID mortalities, but as the pandemic wore on, lesser states had a negative change, and that change was also minimal. In January here, we can see about 10 states had a negative percent change in drug mortalities, but by the time we got to July, only 2 states did, and that was also very minimal. Looking at the COVID-19 mortality analysis, we can see that most of the deaths were concentrated in April, as can be seen by the scale of the graph. And the top 5 locales for each month from March to July of 2020 is also varied compared to what we saw with the drug maps and graphs. Most of the states in there were about the same. We saw the same states be at the top, such as the Dakotas, like we pointed out. But here, most of the locales are shifting each month, but we still see New York City and District of Columbia like we had seen previously. So now we can look at the results of the drug overdose mortality and COVID-19 mortality co-location. These maps show the concentration of the hotspots from March to July. And if we look at March, we can see that the drug overdose mortality hotspots were concentrated near the Northeast United States, whereas there was no significant COVID-19 mortalities at the time, since COVID was just introduced to the United States at the time. But if we look at April, we can see that both drug overdose mortalities and COVID-19 mortalities are concentrated in the Northeast part of the United States, and that is consistent in May as well. But come June, we can see that while drug overdose mortalities are consistent in the Northeast, like we saw previously, COVID-19 mortalities are also in the Northeast, but they're not as strong as they were previously. And as we see in July, the COVID-19 mortality hotspots have completely shifted from the Northeast to the southern belt of the United States, whereas the drug overdose mortalities have remained consistently in the Northeast. So after looking at the state and national levels and seeing the variation throughout the months, I thought it would be more insightful to look at all of our data on a region scale to see if that proves to be more insightful. So here's a map of the United States Census regions for reference, and we will start with the Northeast region. In the bar graph here, we can again see how consistently each state has its mortality rates broken up in drug overdose deaths in each month, which is also what we had noticed previously. And similarly with the COVID-19 bar graph, we can see how irregularly it's broken up, how each state has it slightly differently based off of their individual policies and how they handled COVID-19. What's also important to notice is that the top 4 out of 5 locales for both COVID-19 and drug overdose deaths are the same in the Northeast region. And the same can be said for the Midwest region. The top 4 of 5 locales are consistent for both. And again, we can see the same trends in the bar graphs which we had seen previously. Similarly, with the West region, the top 4 are the same. And we can see what's interesting to notice actually in this one is that the shapes of the bar graphs are different, which generally means there's a different trend in the data, which is unlike what we had seen previously. And then moving on to the South region, both of the graphs have shown trends that we were observing previously, and 3 of the top 5 locales are the same between drug overdose deaths and COVID-19 deaths. In conclusion, drug overdose deaths increased regardless of what was happening with COVID-19 death rates, while COVID-19 death rates fluctuated state by state, depending on the local conditions of weather, treatment, testing, and as well as their policies and business closures. Okay. To answer our first research question of identifying the hotspots of drug overdose deaths and COVID-19 deaths, we have the top 10 locales for each drug overdose mortality and COVID-19 mortalities shown here. And the locales in red are the locales which are similar for both of them. So 5 out of 10 of the locales were similar between both COVID-19 and drug overdose deaths. To answer our second research question of determining if there's any significant increase in drug overdose deaths during the pandemic, our results show that nationally there was an overall increase in drug overdose mortality in some states in the same month when compared against 2019 data. And our third question of seeing if there's any spatial correlation between the deaths by drugs and deaths due to COVID-19, we saw that our spatial collocation did show that there was a spatial correlation between the drug overdose mortalities and COVID-19 mortalities in all the months that were studied except for July. If you guys remember, that's when the hotspot for COVID-19 shifted south. And our regional analysis, which we just looked at, of the top states with higher drug overdose mortalities also coincided with the top states with higher COVID-19 mortalities. Policy implications towards the end of 2020 also helped to, on behalf of COVID-19, also helped those with substance use disorder. For example, implementation of telehealth made it more easy for people to talk to their physicians and get access to treatment, which was previously difficult during the pandemic. And treatment rules were changed to allow 14 or 28 days of medication dispensing instead of requiring daily visits, which made it more convenient for people to access their medication and their treatment. Recommendations going forward would definitely be to continue this study once more data is available by increasing the timescale to include all of 2020 and then narrowing in the location to do it on a county scale when that data is available. So it would be more insightful to see where exactly the problems are and how we can better allocate resources to those areas. Data availability was definitely the biggest limitation in this study, as there is a 6-month lag in drug overdose mortality data availability. And due to that, it was impossible to do analysis of the full 2020 year. And if there was also data available at the county scale, that would have been a lot more insightful for us to narrow down which areas seem to be having the most issues and see if there's correlation in those areas as well. Thank you guys, thank you everyone. And I'll be happy to answer questions and comments during the Q&A. Thank you so much.
Thank you very much. Really do appreciate your presentation. As was mentioned, our next presenter actually has a presentation in a prepared format given inability to attend at present moment. So I'll turn it over to the colleague who is representing Brown. Sabrina Brown.
All right, thank you. I hope to be able to share this correctly, so please bear with me if I mess something up. And can you guys hear my screen?
Pause for a minute. What you may have to do is go into your screen is showing as far as a slide deck, but if you're supposed to be showing a video, it's not showing.
It'll be a slide deck with video sounds.
Okay, so you need to ensure that go into, sorry, just get me. There's an option where you use computer sound, so just give me a second. Okay, so in your left-hand corner where it says mute, click that up arrow and choose computer audio.
It should be using my computer audio. I apologize. I tried to use Zoom, but my Zoom was not as up to date it was supposed to be.
All right, you can try it again. Go ahead. But do you need to advance the slides? So if that, you need to put the slides in an actual show. Yep. Pause again. It's not. We're not hearing it. We're not hearing it. It's far. It sounds distant.
I am so sorry. I did upload the video previously. Let me try just sharing the video instead of the slide deck.
Okay.
Are you able to hear that now?
Yeah, maximize the video if possible.
Oh, I can certainly do that. I just wanted to make before I did anything else.
Okay.
I apologize for the technical difficulties.
It's okay. I'm sorry, the audio is still faint. Are you sharing your audio? Because I think that's what you need to do.
Let me. Pause that for a second.
All right, so go back to when you're on your screen share, there should be at the bottom share audio.
Yeah, I'm trying to find that. I did upload the video. If you have it on your end, I uploaded it yesterday in case this was an issue.
Okay, do me a favor. Drop it for me in the chat box. Let me see if I can do it on my side.
Okay.
The link to the YouTube.
I'm sorry. I'm really sorry.
These things happen.
All right. I have sent the YouTube video for that in the chat.
We can't hear the video.
I had shared the link. Have you received it?
Yeah, it was being shared. It just the sound wasn't
Okay.
popping up again.
You're not hearing the video? Is that what you just said?
Yeah, no sound.
Oh, geez.
It is available though on Whova for people to view after this if they're interested.
Okay. All right, so we'll just try to pivot. Apologize for that. I thought it was playing and I thought it was going through on this end. Okay, so if we can, technical difficulties aside, as was mentioned, Sabrina's content is also available on the online access resources. So if we can go into some of our discussion elements at this present moment, if I can have both Navia and Dr. Powell come back on screen. Thank you. Just wanted to make sure if there are any questions from individuals in the audience, but I'll start with a few moderator questions and then we can jump in, of course, for any additional. If I can ask you this, Navia, one of the interesting things in the overdose deaths that you had highlighted did really, I wanted to see, were there additional opportunities, whether from recommendations or even from data analytical standpoint, around the wraparound services, more particularly the social and behavioral health resources that were available to the same, essentially, demographic that you were looking at for the overdose, related substance use disorder and the overdose related activities, as well as any indication around occupation, meaning of the individuals who were more prone to these related activities, and in an effort to look at the correlation against COVID, was there any kind of occupational settings that provided some insight on the overall impact of COVID on all individuals with respect to substance use disorder?
That's a very good question. So I did not look into demographics for this research. I had looked into demographics for the previous research, but for both of them, I did not look into occupation. I should though, I believe that would be a good thing going forward. So I will include that going forward when I have more data, but I did not look at the occupation or the availability of possible help and treatment sites, although I did plan on doing that. The data for it was not as readily available, so it was not doable for the time frame that I was looking at. But I do agree it would be very insightful to look at that, and it would be very informative to see what that indicates for policy implications and future recommendations. Thank you.
Thank you, Dr. Powell. In your conversation around some of the policy changes with respect to policing and the utilization of, I guess, how do we say this, less of force versus with respect to incarceration, what were, and given contextually before COVID, not before COVID, as we saw last year, some of the related issues around social justice and rates of incarceration in key populations. What has been that shift that you surmise can be seen around both those policing agencies in utilizing incarceration or jailing or imprisonment as a primary tactic, and how well does that flow into the need for more of a community-centered approach that is less of stick versus carrot?
Yeah, so the story that we kind of heard was there was just a routine where there was a violation, there was a warrant, and someone went to jail. And there wasn't a lot of thinking about alternate strategies. And we heard from a few respondents who, one sticks out in my mind, who said, I told them they had to stop doing this because of the pandemic, and now they have to think more carefully, and they're making more referrals and taking more community-based solutions. So it was this really interesting kind of the pandemic as the carrot, where there were all of these incentives to not incarcerate people, not for social justice reasons, for health reasons, but force them to adopt this kind of community-based response instead of just routine, not throwing people, but issuing a warrant that would oftentimes put someone in jail, and just having them take a few more steps to think about what they were doing in the cases. So it was really interesting to hear that kind of silver lining, to use that term again, from it, and forcing people to think differently who often didn't really have a chance to, because of just so many cases, and just trying to stay on top of everything that was required with paperwork and travel and so on. So
as a quick follow-up to that, you kind of mentioned what are the implications when we get back in quote unquote normalcy. Has there been any kind of real substantial commitment from what you've seen, at least with the agencies that you've interacted on this particular aspect, to really truly continue this effort, or is there anticipation of pivoting back to the status quo as before?
So that's a really good question. So in Pennsylvania, the changes have been largely at the discretion of the leaders that we talk to, and there hasn't really been a lot of codified change legislatively. So these reforms are really, depending on the leader that's in place, is going to depend on their durability. So we heard from some, this is our new way of business. We're committed to this kind of more treatment, more community-focused approach. And then we heard from others that kind of suggested that things might slide back to how they used to be. And the problem is that because these things happened at the agency level, and weren't accompanied by like the teeth of legislation, it's not really clear. That could easily happen, right? That slide back and that reversion could easily happen. So there's some that, seem more committed to it in the long term, but of course it's kind of at the whim for as long as they're in this position and the people who they work with continue to follow these policies and these guidance. So we're hopeful, but it's not quite as sure as it could be, I guess.
Great, thank you. Navia, if I can go back to you as well. One of the additional points in your latter slides in your great presentation was around the opportunities to look at key areas of concern. And I say this because I guess just full disclosure, I'm an epidemiologist, work for a national organization that represent local health departments. So we have been also looking at areas that we have called both from the federal in the US, from a federal lens, as well as locally, areas of concern or counties under concern. And what we were able to look at were, where are those COVID hotspots? Meaning, are they sustained for a long period of time? Are they rising new, or are they, plateauing to some extent? So I say that in the context as a lead up, looking at those hotspots for COVID, the opportunity as well within your study to also identify, are they correlated to hotspots that you're seeing for the overdose, deaths and substance use disorder, to some shape or form, to identify any possible connections for intervention strategies?
So as the study showed, there did seem to be a spatial correlation from March to June. In terms of intervention strategies, COVID-19 is a virus based pandemic, and then the drug overdose epidemic is an addiction. So the intervention strategies for the two would be very different, but what I do see a variation in would be the availability of both of their interventions, so to say, where if there's more availability of COVID vaccines and treatments versus where the concentration of addiction help and addiction recovery centers is located. So that might be something in terms of intervention, which might sway where hotspots are between the two.
Thank you. Yeah, I was referencing with respect to intervention, not necessarily intervention for COVID per se, but as a result of having significant hotspot in key areas, which of course has cascading impacts, such as, more strict use of barriers, the lack of, business reopening and those kinds of efforts, which also adds to the social isolation, whether that, and even issues such as social vulnerability, does that correlate, especially with those significant sustained hotspots, in a way to identify or drive opportunities for, looking at, once again, wraparound services. What are the elements to address intervention to reduce the impact on overdose and of course, so that's what I meant for that. So sorry if I wasn't clear.
No, sorry.
No, it's fine. It's totally fine. This is what we do. This is a science at work, science of policy. So given where we are at the time, and once again, we apologize that Dr. Brown's data wasn't able to be presented, but we will once again refer folks to the links. Are there any last comments that either you, Navia, or Dr. Powell would like to say before we close up the session? Okay. Well, we thank you very much. And once again, all participants today. And we hope that this information continues to both feed both our thirst for knowledge, but also for our opportunities to take much of this information and develop implementation strategies that can truly address the linkages between both the public health centers, as well as the law enforcement communities. And this is very firmly understandable in the sense of how our work together is to really, truly for the protection and the health and safety of our communities at large. So with that, we thank you, and we hope that you have a blessed rest of the conference. Be well.
Thank you.
Thank you.